have Andrew coming back again. Tell us about the real world experience.
Thank you very much. Just as context, we have just heard trial data for 156 weeks and also PCV. So what we're going to do now is give you some very early experience that we've had, and we'll be sharing that with our colleagues in the region. So we had reimbursement in October of 2024. And what we have been looking at now is how is our practice changing in terms of what drug we're using and how we're managing our patients. So this is an observational retrospective audit, and we can see here that there has been, since August, where we did actually have some access to 8 milligram, a steady increase in the utilisation of 8 milligrams. I'm going to share with you how this clinical practice is evolving. So let's first look at the collection of patients we have who are treatment naive. Here we have 15 naive eyes which have had at least one follow-up visit after starting 8 milligrams, and they were followed at a mean interval of about 4.6 weeks. This is obviously ongoing, but it is a snapshot in time. We can see here in these naive eyes that there is a significant improvement in vision and CMT just after one injection. So the vision improved with a mean of 5.1 letters, and you can see, I might see if I can get a pointer here. You can see that there, right. 1.5 letters, and also a corresponding reduction in CST by almost 90 microns. And if you compare that to the PULSAR study, it gives us some reassurance that at least in these 15 eyes in the real world, we're achieving a similar gain in vision and a similar response in anatomy. If we look at fluid control just after one injection, about 70% of eyes had an improvement in terms of IRF, SRF. There was also a reduction, but any fluid, about 70%. One injection. And I'll share with you, do you see an improvement immediately? The answer is sometimes you don't. PEDs has been an entity that we're still struggling with. In our series, 10 eyes had some PED, but we can see here that there was a reduction in PED height, and in this particular patient there was a marked reduction, almost complete resolution, just after a single injection. So, in our early audit, in our early experience of naive eyes, there has been a significant improvement in vision of about 5 letters, a very rapid, you will agree, rapid anatomic improvement in fluid control. And this may give us the basis for further and earlier extensions. So let's look at another cohort, the cohort that you're probably going to be looking at as you move from 2 milligrams to 8 milligrams, and that is previously treated patients. Here we can see that previously they had been treated with Avastin, Beovu, 2 milligram Eylea, as well as faricimab. Most eyes, 85% of eyes, were switched from 2 milligrams of Aflibercept. We also looked at atrophy and fibrosis, and we can perhaps discuss this later. 30% had some atrophy, and also these patients had been treated for a long time, a mean treatment duration of 5 years, and had they been treated intensively? Yes. for about 5 injections in the previous 6 months. So you'll have patients like this in the clinic, those that you're treating for a long time, very intensively. And in this group, we had 51 eyes where we had 1 follow-up visit after commencing 8 milligrams. So you'll ask yourself, why would you bother to switch? You'd switch because of 2 main reasons. Firstly, in the hopes of extending the interval between injections. And the second reason why you might switch is that you've got persistent disease activity and you're looking for a better agent to dry. And in our 51 patients, you can see here about 70% of the time when we switched, it was due to persistent disease activity. So if we look at switching, if we're after maintenance of vision and anatomy, we can see here that when we did switch, what is comforting is that they did not lose vision, and there was a slight numerical improvement in visual acuity. So these are patients that you have stable, that are controlled, but you're wishing to extend them to reduce burden. And if you look at this group, if we aim to extend, and we had 15 eyes like this, we were able to extend half of the patients by about 2 weeks. So in our series, we are starting to do it slowly, perhaps at 2-week intervals. And what's comforting here is that there was no change in fluid status as we began to extend these patients. What about the other patients that had disease activity in the hopes that you might be able to control it better? And we had 36 eyes. And here there was a slight improvement, even in this relatively small group, after 1 injection, that they were drier. And if you look at the interval change, obviously 60% remained at 4 weekly, because we were trying to load them, as you might do if you've still got active disease. In terms of safety, there were no safety signals that in our initial real-world experience, no events relating to intraocular inflammation. So if we look at switch patients, which is the group that you'll be looking at probably first of all, there has been a maintenance in vision as well as anatomy. There has been a positive inclination to extend, and there has been no new safety signals. I think Lalit, we are going to move on to some cases now in the real world, right? So we'll hear from all 3 of us. These are our honoraria. This is a cricket theme. I don't play cricket, but I understand you need to start, so I'm the opener.
What is a cricket?
Yeah. So Lalit, why don't you speak to this? You make the rules.
So you open?
Yeah, I'll open. But I think we have to vote as well, you see there. You will vote on which outcomes were of greatest interest to you. You can adjudicate that later. So I'll open. I've got 4 cases to share with you. These are cases which have a little teaching point that might be helpful for you when you begin to use this drug. This is the first case. This was a patient who's Caucasian, 70 years old, and presents with a macular hemorrhage. And the macular bleed was unusual, such that we thought that the patient had polypoidal vasculopathy. Now, if we go back to the PULSAR data which Foraporn presented, 70% were in Asian patients, that is 30% were non-Asian, and this may be one of these non-Asian patients. And if you look at the angiography, both fluorescein and ICG, I think you will agree that this patient most likely has polypoidal disease, an elderly white female. And here at the mat, there's a bleed where the polyp is, and there's quite an exudative response at the macula. So she is a naive eye. This is baseline up here, and I give her 1 dose of Aflibercept 8 milligram. I didn't know what would happen, so I actually called her back 1 week later. And if you look here, it doesn't look any better. In fact, it looks a little bit worse. And I'm thinking to myself, or maybe there's a real exudative response with regards to the blood, because the patient was referred for submacular clot removal. It was quite a significant hemorrhage. I saw her at a month. Again, it didn't seem to move. But when I saw her at 2 months, it was gone. And it remained settled. So what is the teaching point? You can see here too that the macular hemorrhage, as you settle the exudation, gradually dissolves away without the need for any surgical intervention like pneumatic displacement or submacular surgery. So this is a limited initial response to treatment. As we persist, the fluid completely disappears, and the fluid was sustained, and she's now been extended to 8, 12, 16 weeks. Second case. This is a problem case, and you'll have these in your clinic too. Treatment resistance to multiple agents. So you can see here there's a PED with some neurosensory fluid. Here you can see a PED with some fluid here. She's 6'9", and she's been on everything. In fact, she was initially a participant in the HAWK trial. She's been on Aflibercept and faricimab. So when she was on 2 milligrams, there was a little bit of a response early on, but not sustained. Still fluid, and the PED does not change. Then I switched her at some point to faricimab, and you can see here the subneurosensory fluid does settle a little bit, but the PED does not change. And look what happens with 8 milligrams. After 1 injection, after 4 weeks, the PED completely settles and the subretinal fluid resolves, so much so that we begin to extend. So we've gone from 4 weeks to 6 weeks, which is what you would really aim to do. But what happens here is that fluid reaccumulates. And so we tighten the interval up, and the PED and the subretinal fluid go away, and we're now extending out. So the teaching points in this case are that PEDs are often resistant to treatment. Often we have patients like this who have been on multiple agents. 8 milligrams was able to settle the PED, but the caution is not to extend too quickly, even though we hear from the trial data we can go to 16 weeks or 20 weeks. Next patient here is somebody who's really treatment intensive. He's an 81-year-old male, and he keeps recurring in terms of intraretinal fluid in this eye, and we can't extend him beyond 4 to 5 weeks on 2 milligram Aflibercept. And here there's thickening, as you can see here. It comes and goes and comes and goes and just doesn't settle. He travels a lot, and he wanted a durable agent so he didn't have to come every 4 to 5 weeks. Here you can see it's still fluctuating. After 1 injection of Aflibercept, he's dry. After the second one, he's dry, and now we are beginning to stretch him out from 4 to 6, and the aim then is to stretch him further to 8 to 10, depending on his clinical response. So here, this patient has responded well to 8 milligrams of Aflibercept, and the aim of switching this patient is to try for longer durability. My last case is a new diagnosis macular hemorrhage. This is pretty classical of Caucasian females. She has lost vision to 6/18, and there is a vascularized PED. We can see here that after one injection, and this was the case I showed earlier, the PED almost completely flattens together with the subretinal fluid, and after 3-4 injections remaining dry. The interval here is 6 weeks, but the aim is to go longer and longer apart. So the teaching point here is you can achieve, and you will see it, extended treatment intervals with sustained disease.